Well, I can go ahead and get started, and then Babak can take over when he's able to join. I imagine he's just having some audio issues. So, um, welcome to the new team here, and thank you to all the faculty members who are joining. And thank you to the ATC leadership, our Chaley and Don Weed for joining, and all the others who are on the line. I'm Mike Moore. I'm the vice chair of the CDMS, which is a fancy way of abbreviating the curriculum development and maintenance service. So essentially, this is the service that's involved with development of a standardized curriculum for the AHNS ATC accredited fellowships. And so as a part of this portion of the curriculum was spawned, well, we thought of it a few years back, but it really was spurred on by the COVID crisis as a mechanism for communicating and providing a learning venue for all trainees. And so, tonight's session, a lot of it is introduction to the curriculum, and appreciate many program directors joining us for it to also provide their feedback. And then Ara and Don are going to spend some time going through some other aspects, everything from the entry into the case log. I know Babak's going to give some intro into that as well. And then at the very end, we were just going to provide a sample case. These tumor board sessions, when we have them, and we'll send out to you guys the running schedule of this. They'll be held every other week or so over the course of the year. I think we have between 22 to 24 sessions total. And the goal is to have 3 cases per session, presented in pretty much a tumor board format. And the idea is to have the main presenters presented, and then we'll have discussants from the AHNS who are contributing to technical details, and oftentimes there'll be controversies in management and workup, and then providing some evidence-based background for why we do what we do. And then we'll give you an introduction in each session and kind of give you some understanding of how best to learn from them. But the idea is they're meant to be a way of just seeing different people's approach to similar things. I think we all learn different ways of doing it in our training, and I think that's why these sessions, at least for me, have been so beneficial, is just learning how other people attack challenging problems. So why don't I know, JJ, we were going to plan to do a sharing screen on the operative log. If you have this available, and then
yeah. Let me just, yeah, I'll share my screen in a second. Let me just ask everybody, if you are not speaking, please mute your phone. We're getting a background. I may be able to do some of it from my side. Go ahead.
So JJ, you're gonna load up the screen share?
I am. I'm doing that right now.
Hey, Mike, you okay if I make a couple of comments?
Yeah, that'd be great. Thank you, Ara.
Yeah. Well, Mike, thanks for pulling everybody together, and on behalf of the ATC and Don Weed, who's on the line, the synergy between the ATC and the curriculum development team has been fantastic, and it's really, I think, helped the fellows and the program directors realize they're in a community. So it's been educationally supportive, and also, I think, professionally, fellowship-wise, the community we have, the village we live in, it's been nice to build that out during these hard times. We actually have a couple of asks, and it's a shared ask between the ATC and the curriculum team. One is to participate in these programs and share your experiences. Number 2, the case log system, which Babak will walk you all through, is really an important tool for us, because each of you are going to have varied experiences. We aren't really sure what the COVID situation is going to turn into and how it's going to affect training. The work we did in the springtime to assess the programs, assure progress, showed that by the time COVID really hit, the programs and the fellows were feeling pretty comfortable in their training. What we see now is that if there's a variance in that, we really want to have a heads up on how each program is progressing through the case log experiences at least. So please stay up to date on your case logs, the case log entries. If you have questions on how to do it or you see opportunity, give us feedback. But it will be really important. It'll help your program director too, and it'll help us explore solutions if we need to explore solutions like we rapidly did in March. So that's really our main pitch. And then for you all who are program directors who have joined, again, thank you for working together with the ATC and the CDMS and providing a quality training experience, but as well to being innovative and helping your fellows get through the process, and also being innovative in your virtual interview platform and your approach to helping our new candidates know about the opportunities. And so if you do have learnings from that, also please share them with us. Don, any other thoughts or things that we needed to bring up today?
Yeah, I would just echo with regard to the case log. Just super important for you to update in a real-time fashion. And ideally, that would be weekly at the absolute latest. We really want everybody with an accurate, updated list monthly, no more than that, because we're in a situation now where who knows what next week will bring. So this is going to change a lot over the next month or two, and hopefully we'll settle down. But anyway, we just need everybody to stay up to date, and again, echo the plea to the program directors to help remind your fellows.
Yeah. To that end, we are going to be looking at that. So of course, we'll give you feedback, understanding there's always situations that may require variance. It's going to be collegial feedback to help keep everybody up to date. Thank you. All right. JJ, you have
this is going to be pretty quick. I think hopefully by now, you have received your login information for the TRES system. For the program directors who are on the call, your login system hasn't changed, but my hunch is probably most of you don't have it from last year. So what I'll do probably tomorrow is resend. You can get in there and look at what your fellows are seeing. Once again, ask everyone to mute if you are not muted already. I think I can go through and mute a few of these just so we don't have background noise. Okay, so when you log in to the system, the shared screen is the first thing that you see. Most of these are just general updates from the TRES system themselves, nothing usually that pertains to us specifically, unless there are reasons that the system's going to be shut down or whatever. When you are ready to log a case, you go to Activities, which is here, and click on New Activity, enter New Activity. Okay, and then what you get there is the case log. I think from there, it's pretty self-explanatory. You have your date of operation, which is just, of course, a calendar that you can click on. Attending physician. Because we now have 50 programs that share this system, the only attendings we have listed are your program directors. So if you're working with another faculty within your program, what you'll need to do is enter them by using the other tab. I know that's a little bit of a delay, but it was either that or have a list of 300 doctors in this drop down, and we felt like that was more than was feasible or helpful. So if your program director is listed, and there are a few updates that'll be made tonight on that. I think there are a couple of folks who've changed titles, which I'll update. But if it is another faculty member, please take the moment to click on Other, and then you can fill the name in here as you see. Okay. We are, okay, then you go to patient information. You know what, I need to send to you all, and I just remembered this. We had come up with a formula, I believe, for the unique ID of the patient, and I will find that tonight when the case starts, and I will email that out
Well,
to you
okay.
so that we can maintain a consistent ID nomenclature as you're entering the patients. We want to make it as unique for each patient as we can. Then it's pretty self-explanatory: gender, date of birth, first name only, and then the diagnosis. Everything is drop-down menus. We are working very shortly. We will revise this list and add a few things to it. Within each of the categories, there is a drop-down for different diagnoses, and there is also the other category here as well. I would encourage you to make sure that that what you're looking for is not in the drop-down before you go to other. We had a number of extra added cases, some that duplicated what was already in the drop-down last year. So just make sure, just double check to see if you can find the diagnoses in what's available before you use the other tab. And then same thing with complications. We try, and also if you go through this list as a fellow, if you're working on this and you realize there's something in there that you use quite frequently that we don't have listed, these lists within the resilience software folks, it's very easy to send them an update and ask them to add this, take away that, change the wording on that. They can do that really pretty, like within a day or two turnaround. So if you are finding, or if there are things you aren't finding or pieces that you think should be added, please just email me, and I'll confirm it with our faculty, and then we will ask the TRES folks to enter it. Then you've got up to 6 procedures for each patient. So, and again, your procedure list is another drop-down menu. And I would, again, encourage you to please double and triple check to make sure that the procedure isn't already listed before you go to the other category. Like I said, we're in the process. Probably in the next 48 to 72 hours, we will revise this list somewhat, and I will let you know when that happens. But it's pretty comprehensive at the moment, and as I said, we're always looking to improve it. But try to use that as much as you can, and use other as sparingly as you can. The next, for each of these 6 procedures, you want to make sure you indicate what your role is: primary, first assistant, second assistant, or just observer. And then finally, what kind of an approach you're using for the procedure. So for each of your patients, you have 6 possible procedures. And then there are also other notes. These notes are actually yours. I don't think, like when I pull a report for a fellow, I'm pretty sure these notes don't come into what I pull. So this is just information for you with the patient as needed. And then once you're completed, you can save. If you're entering number of cases, you can hit save and new, and it'll save this one and immediately open up another, etc. So that's it's a pretty easy system to enter material in. The trick is just making sure that the material, that the data that you're entering is as correct as it can be. And as Don and Ara said, as we're going to be watching very closely what's going on in the country in the next couple of months, we've had the TRES system in place now for, I think this is our 3rd year. And inevitably, there are those fellows who will wait 3 or 4 or 5, 6 months before they decide to start entering cases. That's typically that we would let that slide. This year we really can't. As Don and Ara said, we really need to do this as much in real time as we can, just so that we have tabs on how you're proceeding, if the volume that you need for the education that you're receiving is sufficient. And we will be periodically checking. I also am going to install on this they have an inactivity monitor. So after about, I think probably 3 or 4 weeks, if there hasn't been any activity, I just get an alert. And that doesn't mean you're in trouble. That just means I'm going to throw you an email saying, yo, please, please fill in your case logs, because we don't want you to get too far behind so that any detail or data is lost. That's it, kind of in a quick nutshell. Anybody have any questions, or faculty, is there anything else that I need to cover that I haven't?
JJ, are you the resource for questions? If a fellow has, or a program director has issues accessing or has questions,
Yes.
are you the person?
Yeah. Any access questions, any procedural list, anything having to do with TRES, feel free to send it to me. We have a representative at TRES. His name is Alex. He is new, but his predecessor worked with him for a couple of months, and he understands what we're doing. And he's got a pretty fast turnaround track record in the few months I've been working with him. So yeah, send anything to me and I will convey it to the TRES folks. I've had a couple, if you talk to fellows who are not in AHNS accredited programs, a couple of requests for case log accounts. Just keep in mind that these accounts are only for the accredited programs of the American Head and Neck Society, of which there are 50. I've had, like I said, a couple of folks from outside have heard about this, and they may join us as guests, from what I understand. But only the Head and Neck fellows, the Head and Neck Society fellows, will get an account assigned to them. At the end of the year, you'll be asked to turn in evaluations and certificate requests and all that good stuff. You don't have to worry about ever turning in a case log. Your faculty will have access to review what you're doing, and I have the ability to pull records at any point. So you don't have to worry about turning anything in with this. We are monitoring this in real time. That's all I've got. Any questions? If there's something you want to ask out loud, do it. If you want to throw me an email, please feel free to send me an email as well.
JJ, thank you very much.
I'll go ahead and stop.
Well, I did want to cover some of the other aspects of the curriculum. Dr. Givey will join us shortly. He's actually presenting on an analogous tumor board for the endocrine section, and he'll be coming on here in a moment. But I know he's very excited to welcome the new team and new group. So a few years back, Babak had done essentially a gap analysis or a survey of the program directors, and also gotten a lot of feedback from fellows to try and really tease out what are the most important aspects to incorporate in the training. And as a part of that, a group of us then broke off and developed something kind of akin to cochlea, but much more specific to head and neck related topics. And that was, I think, issued first for the first time last year. Essentially, it's broken down in
Uh-oh. I think yeah, hang on, folks. I think we lost connection with Mike. Let me see if I can bring that back.
You guys hear me?
Yep.
You guys hear me? Okay.
Yeah.
All right. Very good. Sorry about that. I guess I don't live as close to civilization as I thought. But in reality, they had put a lot of work into revamping the reading list and really distilling it down into important articles relative to each of the individual subsites. And I will say many of you will actively recruit over time and be excited to have you involved in this process moving forward. I can say just in welcoming you to the family, if you will, we're very excited to have you aboard, very excited to be able to work with you not only this year, but in years to come. You know, it's the year you have ahead of you is one of the best you'll ever have in your life. It's really an enjoyable experience, and you learn a lot of skills, not just with regards to patient care, but also getting to meet a lot of great colleagues. I'm having all kinds of issues with my audio. Can you guys hear me okay? Just give me a thumbs up because I can't hear anything on this end. So, okay, sorry. Yeah, even it keeps like muting on this end for some reason. And that will be available on the site, on the AHNS site. If you go to the Curriculum Development and Maintenance Service, there's a downloadable option there. You can also find information on the case log, and then we'll make sure we have uploaded the planned schedule for this year, as I mentioned, those virtual tumor board sessions. I'm wanting to present my case, but I got to figure out a way to get audio here before I do that. So
let me jump in. Let me jump in real quick and also say the curriculum that has been revamped. I'm actually at this moment in the process of just fixing the page numbers on it. It was a bit of a mess, and I'll have that posted within the next hour. So I'll email that to the fellows. I don't know if you had mentioned that, Mike, but that's that'll be up on the site very, very shortly.
And JJ, you have the exact instructions for people like me not savvy on the T-Res and how to get all that information on that site as well. It's just kind of one consolidated package for the fellows.
Yes, yes.
All right.
Okay. Hi guys, that's Babak. Sorry, I was on the webinar for endocrine. Joined late.
No problem. How's it going?
Good.
Hey, Babak.
Hello. Where are we?
Your timing is perfect, actually. We went through some of the basics of the journey to the curriculum that you had put forth, and the second edition and how that had come to pass, and then the schedule for the virtual tumor boards. Ara and Don had provided perspective on the T-Res and just the interaction between the ATC and the CDMS. And JJ given kind of a live demonstration of the T-Res and how to enter things. So I think it's a good time for a few comments by you, and then we'll plan to lead into the case discussion.
Okay, sounds good. Yeah, so welcome everybody. We're very excited to have you. I think whoever wanted to live in interesting times really got their wish, because you were the first class that has started in a pandemic since 1918. I don't know if they had a next fellow back then. So welcome. It's a couple of housekeeping. First of all, use us as a resource. We're all here for you guys. This entire effort is for you to learn what we are trying to do. And this is an idea that we have had for years, and it just COVID-19 propelled it to the forefront. And the idea is to have a virtual tumor board that we can discuss cases, and you can see that there are different ways of doing things. We try to do more unusual, more interesting cases, not routine cases. Mike and I and others are working on a collection of usual routine cases that's going to be published hopefully next year. So this is considered to be a complement to that. I do encourage you to enter your cases and maintain a case log. It's extremely important. When I started at my institution, a lot of people questioned my credentials, and having a case log was very, very helpful. We would like to hear from you. We would like to know what you feel and what we can do to make it better. The curriculum 2.0 is going to go live tomorrow, I think. And use it as a resource. It's been completely updated for the resource, for the references. So you're going to have all the newest, best papers and classic papers in there. Eventually, we would like you guys to also present some cases and discuss it. And we encourage you. We don't expect you to do it, but we really encourage you, and take it as a podium for your next endeavors. And the last thing I would tell you is fellowship year goes very fast. And believe it or not, it's one of the best years of your life. You're going to have a lot of fun. You're going to do amazing cases. You're going to develop best friendships. So really enjoy it and cherish it. All right, Mike, we're ready to hear your case.
Oh, sure. Yeah, let me see here. Share screen. All right, you guys see that all right?
Yeah.
Yes.
If you just
All
put
right.
on present, yeah, perfect.
There we go. All right. So this is a relatively bread and butter one, but I think curious to get some input from the group. So for these, just to go through some of the way we found it made it work a little bit more smoothly. It's difficult to do the hand raising and everything else. So for these sessions, the way we've used it in the past and the feedback we've gotten had been constructive on this so far is enter questions through the chat box, either to the group or specifically, in this case, probably to Babak, and then he'll, in intermittent portions during the presentation, bring up questions, and the idea is to get discussion from the faculty who have called in. Our concern of opening it up entirely to the floor is it may lead to mayhem, and when we're trying to get through 3 cases in an hour, it sometimes is difficult to do that in larger group discussions. But certainly we're open to feedback along the way in between sessions if there's additional questions that come up. So this is a 54-year-old who came to see me. He had had kind of a slow onset of noisy breathing, especially when lying supine at night and snoring. He saw his primary doctor initially, and they were concerned for initially peritonsillar abscess, but obviously from the standpoint of our evaluation, it didn't seem to make sense. The patient really denied any other symptoms. They were tolerating a normal diet, no pain, no trismus, no neurologic symptoms whatsoever. And so obviously started with a physical exam, and this is just a representative transoral view of it. And you can see on that left side a bulge of the soft palate, deviating a uvula over a little bit. Really no trismus, though. I really had next to no other associated issues found on physical exam other than a prominence of the lateral pharyngeal wall on endoscopy. You could feel a submucosal mobile mass, and both on the bimanual exam and both transorally as well as underneath the angle of the mandible. And
Okay.
you know, for assessment of infectious causes, there was really no induration or any fluctuance on physical exam, and obviously no trismus as we discussed.
All right, so let's see. What's your preferred imaging? Let's just start with Jeff. Jeff, you're the man. So how would you like when you see these things? What do you start with? Do you like CT or you like MRI or?
I mean, I think CT is sort of like an easy, straightforward test to get started with. I think usually the timing is more readily available, and a lot of times you're going to want a CT and MRI anyway. I think this lesion is likely to be a soft tissue lesion in the parapharyngeal space given its presentation. So an MRI I'm probably going to get later, but I think a CT is a good first step. I think some of the presentation elements are really key to pick up. One is that there's no trismus, which this area, the pterygoid musculature is nearby, so that gives you some information. And the normal facial function, I think, is a critical thing to understand too, in terms of, you know, deep low parotid tumors that also might be related. So those are some critical physical findings I think help you shape in your mind already what's going on.
All right. Anybody who just started with an MRI, Don or Ara or Susan, I see.
I mean, I have to say, just from a practical perspective, most of the patients I see already have a CT, so I'm often getting an MRI as my first test. But if I saw somebody without any workup, with no trismus, I think an MRI would be a pretty nice way to go.
Yeah, I like MRI for this as well, just for the soft tissue delineation.
Yeah. All right, we don't want you to get into. Are you driving?
I might be driving, but I'm not looking. But I'm thinking.
Is this how we're gonna teach fellows to, like, let me do this operation while I'm dying? Where are you? I-95 or 91? Jesus. All right.
Yeah. So our radiologist really loves the MRI for the higher area of the neck, so that you ameliorate some of the dental artifact and but I think both tests are a good point to start with.
Yeah. So the point of this, and for everybody, is I completely agree with everything you said. You know, I think the technology has changed. As you can see nowadays, with the better MRIs, and thankfully it's getting a little bit cheaper, it's not wrong to go start with an MRI in some cases. But Jeff is absolutely right. For a lot of patients, a lot of situations, CT is quick, fast, get it done. In this particular spot, and especially when you're thinking about the soft tissue process, and you want to look at the peripheral space, and you don't want to get the dental artifact in your way, I think MRI is also very reasonable. All right, Mike, yours.
Yeah, so I think all great comments. This person came in with a CT. They were claustrophobic, and with his OSA sort of symptoms, we didn't think that sedating for an MRI was appropriate. So we ended up just going with a CT. We did, well, I guess the question to the group would be biopsy or not, as far as whether you would and whether it would impact what you were doing.
That's a great point. Do you want to show the CT images first?
Sure.
Okay. Wow, we got a juicy one. All right. Let's see. Anybody wants to read the CT? I guess, Mike, would you like to comment?
Yeah, I can just go through it in the interest of time here. Yeah, so the submucosal mass, kind of heterogeneous in nature. A little tough to tell here, but as scrolling through it, seems relatively well-defined margins. This is more of a cut through the retromandibular vein and another adjacent branch. So kind of a butt of the deep lobe. It's hard to tell if it was a narrow interface or if it was truly arising from the deep lobe itself. This little speck here is actually the point of the styloid, very near the deep aspect of the tumor, and the carotid artery was posterior to it, and the parapharyngeal fat had been flattened posterolaterally, which gives some insight onto the pre-styloid versus post-styloid location. CT does go a little higher than some as far as the location of the upper aspect of the mass. But no obvious bone erosion. And obviously, like I said, no obvious pterygoid muscle involvement. Again, that was as much as anything highlighted by the lack of trismus on physical exam. Transoral fine-needle aspiration was consistent with the pleomorphic adenoma.
All right, so it's a great stuff. So let's not look at the last line, but what would be your threshold to do biopsy? Jeff, let's say this guy comes to you and this is your CT. Do you routinely biopsy, or you don't sometimes say, it's benign?
I, broadly speaking, for head and neck masses, will try to obtain a fine needle aspiration biopsy. I think in general, you want to know what you're getting into before you make your incision. You know, if you take this entire presentation and you say, if you do the FNA and you say, you know, if they said malignant cells concerning for carcinoma, it changes immediately your conversation with the patient. It changes how you think about the problem. It changes how your operation is going to go. So I think these kind of maximizing your workup to have the maximum information before you go to the operating room, including an FNA biopsy, is really key. And like Mike, I would have done a transoral FNA. It feels a little weird sometimes to be sticking a needle in the mouth to take a sample, but I've done it a couple of times, and I think it's a reasonable, appropriate approach than to try to some, low transcervical approach that might be difficult.
I think that's what Mike said, that they also did transoral. Yeah, I agree. And I know we are oncologists, and I completely agree, and I have a very low threshold to biopsy. The one thing about pleos have a very distinct MRI image. And if I have my best neuroradiologist look at it, and this is 100% a pleo, I do believe them. But in general, something this big, I don't think anybody would, could criticize or say you're too cautious to biopsy. Don and Susan, and I'm not going to ask Ara because there's a traffic jam in Philadelphia.
I agree. Definitely, I'd like to have a biopsy before I start.
Okay.
I would definitely biopsy, but I would only add that it's critical to have the imaging first, because there's some pretty vascular lesions in this area, and you definitely need to understand what you're biopsying. And that would be the one scenario where if you have a vascular lesion that you don't think is a paraganglioma, but you still want to biopsy, I might do an image-guided lateral approach as opposed to transoral. Otherwise, transoral is perfect for this.
Yeah, I agree. All right. Ara, if you're keeping your hands at 10 and 2, would you like to make a comment?
I yeah, you know, the image guidance is really great. And so if your lesion was smaller and you saw it clinically, but you really weren't sure whether you could get there, the image guidance is a key element. So CT guided transfacial or lateral is really very helpful. And I agree. The more you know, the more you can do, especially in our current zest to be minimally invasive. So, and also to inform the patient more fully. These are important adjuncts to the treatment plan.
All right. So question for the group, while we are at the topic of MRI versus CT, one of the audience is asking, do we feel MRI is better than CT to accurately find extranodal extension? That's a great question. I will go first. I say, you know, we are all more comfortable with CT when it comes to extranodal extension. That's number one. Number two is, remember, there's a paper from Pittsburgh, I think, that they looked up to see how accurately we can identify true pathologic extranodal extension by imaging. And none of these imaging are 100%. A lot of times you see, and you say, oh my God, there is extracapsular extension. When you take the tumor out, it actually not pathologically have extranodal extension. That's a pathologic finding, not an image kind. You could, you know, some big Goomba, you see them like destroying everything, not a big deal. But short of that, is really hard. Now, the new MRI sequences are very sensitive, and you actually can see if they are invading the muscle or not with those. But that requires you to be very well versed with your neuroradiologist, and sometimes they have to do extra sequences to get you that. So I would say, see what you have in your environment. Both CT and MRI are good. The majority of us are more comfortable with neck node with CT, but MRI is getting better and better. Any other comments, Don or Jeff or Susan? What would you do for extranodal extension?
I mean,
I don't have anything to add to that.
not so much as it relates to this case, but everything you said, I agree with Babak, and that imaging generally is kind of iffy, and MRI versus CT are still not as great as taking out the specimen and showing it from pathology.
Yeah. All right. So, Mike?
Well, this leads us to our next question.
Yes. All right. So
What do we
I'm not going to
do?
say anything. Who should we ask Susan?
What?
What would you like to do with this case?
I would prepare the patient for a transcervical approach, but I would be prepared to do a transparotid or a lip split mandibulotomy if I have to. But I've had good luck with transcervical approach. So.
Any particular style that how would you do when you do these transcervical? What are your steps?
So, you know, I start with like a regular neck dissection approach. I find that typically there's a packet of lymph nodes in the jugulogastric region that if you take those out, that kind of frees things up. And often I'll go ahead and do level 1, take the submandibular gland out. I mean, traditionally we talk about splitting the digastric and the stylomandibular ligament and really retracting the mandible up as far as you can. And then depending on the texture of the tumor and the pathology, the histology, if you have it ahead of time, you know, you can do a fair amount of blunt dissection and mobilization. And with, you know, another hand in the mouth to kind of deliver the tumor through the neck, you know, you can get a surprisingly large tumor out of the parapharyngeal space that way.
Yeah, it's excellent. Those are very fantastic points. I mean, Jeff and I are both Memorial, so we have our kind of very similar approaches. Let's see, Don, what are your kind of pearls for the fellows when you do these?
So for something this size, particularly that closely approximated to the pharynx and high, we didn't see a kind of the image of the skull base. But first thing I would say is I agree with transcervical, transparotid. This seems like it's involving deep lobe. It could be minor salivary abutting deep lobe, but I think you have to assume it involves the deep lobe. And I think while the traditional parapharyngeal space approach, you just go above or through the digastric and release the ligament and retract the mandible, which gives you a lot. Actually dissecting the facial nerve and removing the inferior superficial and deep lobe parotid and really mobilizing the facial nerve extratemporally gives you a lot more. So I would absolutely be prepared for that. I wouldn't be hesitant to add a transoral exposure if need be. And again, depending on where this looks relative to the stylomastoid foramen, et cetera, even a transmastoid approach short of, you know, just facial nerve relocation is yet another step if you have to get that much higher. I do everything possible to avoid a transmandibular approach. So I would not split the mandible or particularly if they have no trismus. I think you just have options with transoral and transurban.
Yes. Okay. Fantastic. Jeff
think,
or Ara? Yeah, go ahead.
I think one of the tricks for these cases also is to consider nasal intubation.
Yeah.
When you
Yeah.
when you close the mouth and the tube is in the nose or in the mouth, that extra like centimeter and a half can make all the difference from the transcervical access. I know everyone else is saying, yeah, nodding their heads on the phone, so I wanted to bring that up.
Yeah. So I used to do these with Shah a few times, and I can't take credit for his technique, but his technique was exactly what Susan and Jeff and Ara and Don mentioned. There are 3 maneuvers. He used to say there are 3 maneuvers you can do to open up the parapharyngeal space. One is once you expose it, first find the facial nerve and put the lower division up above the mandible. So you know it's out of your way. You're not worried about you looking at it. Number 2, he would divide the digastric completely and the stylohyoid. Number 3, if it needed more space posteriorly, would go and just divide the styloid process, just take it out, throw it out. And then the last thing you can do, and sometimes that's for tumors that are more anterior, you can find the external carotid, and if you divide the external carotid deep to the mandible, that gives you a little bit more exposure. With those 3 maneuvers, you can take a lot of the stuff out. And then there is another technique that I was doing it just today, is you can put a tiny endoscope and you can go all the way up, and once you see those attachments, you start trying with the finger dissection, doing that, you can get a nice harmonic and just cut them and mobilize the tumor. And the view that you get is really nice. It does make a huge difference for you. So those are the tricks that I would do. But I have never needed to do a mandible split for a benign tumor. I know for malignant it's different. Ara,
Yeah,
you're
so
not getting into an accident.
No, I'm slowing down because this is so good.
Like from 100, you're going to 80 now?
Yeah, well, for me, that's slow. So if this was truly a parapharyngeal space lesion, because we're best buddies with the robot, we would actually consider doing this transorally. And the maneuver is very similar to the maneuver that you do in a radical tonsillectomy to get deep to the constrictor, and the blunt dissection reveals things. The big difference is if this was deep lobe and we thought it was potentially distinct enough that you could safely work through it transorally, we would actually potentially do a hybrid approach where we find the trunk of the facial nerve and lay it out either before going into the transoral approach, or do the transoral approach. If it looks like we really need to see that nerve, find the nerve, put a barrier under the nerve, and then take it out transorally. But those classic steps that you've described are the key things to really remember. I think using the robot for this is not ideal for a really big lesion. If you're starting out, it's also not ideal for a question mark that could definitely be deep lobe, and it's definitely not ideal for most of the malignancies that are higher grade malignancies of the parotid deep lobe.
All right, Mike.
Well, this is.
Do you have any question for other things? Is there anything you would like to discuss further before you show us your hand?
Well, I think all these points are very good ones, and I think it really outlines the ways of optimizing essentially the transcervical approach, which you may supplement that with transoral, or for certainly favorable lesions that seem to be truly only a minor salivary rest in the peripharyngeal space, possibly a transoral approach. But yeah, I would have to agree with all that's been said. I think the subtleties like the nasal intubation and things like that, they shouldn't be underestimated. This person came to me with the idea that we were going to do transmandibular. I told him I most certainly was most likely not going to have to, but we drew it out just in case. And again, I've never actually had to do that for a benign tumor either, so I agree with you. Similar approach, doing just transcervical, and then yes, taking out the submandibular gland. I like to leave a little bridge of skin below the ear if I don't have to fully mobilize nerve, because when I have somebody yanking up, I want that tension to be on the skin, not on the nerve. So if you have it really pedicle just on the facial nerve, then you sometimes worry about that.
Yeah.
But getting the gland out of the way does give you more ability to get room there. And I agree with Susan in taking out the level 2 nodes. It gives you good delineation of your cranial nerves and also just more room to see the vessels and everything else. I'll talk to these patients about things like transient marginal weakness, potentially from the retraction, the potential for first bite syndrome, in addition to, in ones like this, you have to discuss a remote chance of tumor spillage. Fortunately, it did not happen here, but it is a real problem. And I think one of the things I do to try and minimize that is in the very beginning, before I really start doing much blunt dissection, is I'll stick my finger in and out fracture the styloid process. You could see back on the image a while back, it's sitting right behind there. So if you start putting any pressure on that mass, it's going to puncture it, and you're going to be feeling like you're making progress, and you're going to pull it out, and there's going to be stuff spilling all over the place, which is a bad deal for the patient. And obviously, if I've seen patients come in with a history of prior operations, and they have seeded tumor everywhere in the peripharyngeal space, and that's a mess. So outside of that, a lot of what was discussed. So the just slow and steady releasing the stylomandibular ligament gives you that little extra retraction as well. And then if needed, you can supplement just with a finger in the back to help get that downward pressure down. This is after the tumor. We kind of it's one of those fine lines. You want to get close to the tumor, but not too close. So you want to get right on that outer part of the, just outside of the main interface with the tumor, and not disrupt the kind of pseudocapsule that's around it. And then also, a lot of times you can get that lateral plane just on the inside of that medial pterygoid. That really delineates your superficial plane. And so you kind of work those two planes, and then just take your time at the end. There's always a point where it's really tempting to want to just get in there and pull it out. And in reality, that's that extra time you need to take just to make sure it comes out smooth. This is not a race. Just get it out safely. So this is a tumor a little over 7 centimeters. There was a very narrow attachment to the deep lobe parotid. We use that retromandibular vein as a guide and really took it in a very methodical fashion of, making sure it looks safe, stimulating to confirm, and then just a little bit at a time coming across that. That part took obviously the longest. But I would say, and I'll show an example of a different tumor, not in the same one, but just to highlight it, there are ones you really need to do a true transparotid approach, a much broader base, something going through that stylomandibular tunnel. And this is just the whole once we're done at the end, as well, with everything laid out. This was the example I was mentioning. So this is one where an MRI is really helpful to show that deep lobe, and you can tell that's going to be pushing that facial nerve up. So this is not one that you can take that approach. You would fracture it right there at that little neck and leave tumor everywhere, which would be a disaster for that patient. So that's one where you want to go in and truly do a kind of a transcervical and transparotid approach, combining that to really, as safely as you can, remove the tumor.
Mike, how long did it take you to do this?
I don't know, maybe like 3.5 hours or something. I'm slow though.
No, I'm slow too. The question from the audience is how long should you book this? In general, the first 2 years you're out of fellowship, everything you see, just double it. Because all gonna love you, the person who's gonna follow you is gonna love you, because you're only gonna look good. Let's say you book a thyroid for 3 hours, you're done in an hour and a half. Everyone says, oh, Dr. So-and-so took the thyroid, you finished the 3-hour case in 2 hours. But if you booked for like 2.5 hours, and you go from 3, and you say, oh, that guy is so slow. So in general, don't put, it's like for us when we do micro, you know, when you come out, never put the tourniquet for a fibula at like 60 minutes. Just put it at 90 minutes, be done with it. You know, you don't put any tension. And by the time goes by, you might be able to take the fibula out in like 40 minutes. Doesn't matter. But in the beginning, just go slow and steady. And I really couldn't agree more with what Mike said. That out fracturing, I'll tell you, that is styloid thing is like a dagger. And if you manipulate the tumor too much, for some reason, it just goes right into the tumor and explodes it. So it's really important to out fracture it or cut it out early in the process. Personally, I've never taken out submandibular gland, but I think that's a fantastic trick, and I don't see any reason why not we should use it. So it seemed like you didn't even need to divide the digastric there.
Yeah, we didn't. We were able to mobilize it actually over top it. I've left the gland in a few times, and they can get some raging sialadenitis just from retraction, I've found. So I don't know. Fool me once or twice, and eventually I just start taking it out. But it's not necessary. I think you can get it out, but it ends up usually dividing a bit more muscle to get there. But I think you can certainly do it either way.
Sure. And also, I agree with you in terms of the, unfortunately, no matter how good of a job we do, they do have a high degree of getting first by syndrome. It's just a dissection in the peripheral space. There's nothing you can do about it. And a good number of them will get, some of them will eventually get better, but some of them, unfortunately, will be better.
And yeah, to answer your question, I think I booked this one for 5 hours. So yeah, in reality, this is one that you just tell them it's going to be a long thing, and hopefully it ends up being faster, but you don't want to rush it. So just go back to the key points. So these tumors in the peripharyngeal space, a lot of times the small ones are going to be incidental findings. And if they're small and an older person with bad comorbidities and it looks like a pleomorphic, you potentially could consider even observing it. But in reality, a lot of times it's prudent to take it out. Just depends on the circumstance. But when they actually develop symptoms from it, it's either usually because it's malignant or it's just getting to that critical size that's starting to cause mass effect on things. Imaging is important to delineate between the pre and post styloid space. I agree. MRI is better because it shows a better appreciation of the peripharyngeal fat and where the vessels can be assessed on either one, but I think the fat assessment's a bit easier on MRI. And it does, I've been shocked with salivary tumors where it looks like you can tell where it ends on a CT, and then there's a much more of an extent, especially for pleomorphics on MRI. So I absolutely agree with that as a good way to go. But either one can provide important information, but MRI is nice when you can get it. And then, the full gamut of surgical approaches. I agree the transmandibular is virtually never really needed unless it's a malignancy or a very vascular tumor that you really don't think you can get good exposure safely otherwise. I found you actually don't get a ton of additional exposure if you really widely open the soft tissue envelope and take your time. You can really get to the same place the majority of the time. Transoral, I have a little but not a ton of experience with that, more in the context of retropharyngeal nodes, but in reality, it's certainly been described safely being done for peripharyngeal space tumors. But as Dr. Chalian mentioned it, you really need one that has minimal to no attachment to the deep lobe of the parotid to make sure it's safe. And it's certainly not one for large tumors early in your career. You want to really make sure you get it out safely for them. Subtle tips, the nasal intubation is key, fracturing of the styloid, removal of the submandibular gland, although not necessary, can be helpful. And then when there's significant involvement of the deep lobe of the parotid, a transparotid approach and really delineating the facial nerve can be critical. And I just emphasize that last line of taking your time. Take your time, it's well worth it. These are ones that even though it doesn't seem like you do a lot, you're pretty worn out at the end just because you're really wanting to make sure it's done the right way. So.
I completely agree. And again, once you start it, it's a good idea just to find a facial nerve and just put it away. It makes you much more comfortable, and it actually makes you much more aggressive to dissect around because you know where the nerve is.
Absolutely. Yeah, you can see the plane of it. I agree. Exactly.
Okay, it's almost 8 o'clock. Any last comments about the case? Open the floor. Ara, if you're not getting into an accident. Any comments? Don, Susan, Jeff?
Bob, I have a quick take home. So when you get your pathology report, it's going to say, negative margin excision, but the closest margin is going to be less than 1 millimeter from the ink. And then they'll be like, oh, is it a close margin? Do I need to consider radiation? I think it's really important that for these benign tumors, you expect the margin to be extremely close to the capsule because that's how the surgery is performed. Just like if you had done a pleomorphic adenoma for a superficial parotidectomy and you had to dissect the nerve off of the capsule. So don't be tempted to be like, oh my gosh, I have to give radiation because I had a close margin, when the surgery itself is going to, by definition, all the margins are going to be close. So I just wanted to put that as a back end take home.
Absolutely. Excellent point. Yeah, I would not chase margins in benign tumors. Yeah.
I would just add that if you want an unhappy patient, don't tell them about first bite pain pre-op. That's the biggest mistake you can make for this case. So you got to talk about that. And I would echo Susan's comment about just get level 2 nodes out of the way, define internal carotid, define your cranial nerves. It takes 2 minutes, and you get a lot by doing that.
Yeah, I can't agree more. This is one operation among many that really knowing all where your structures are and go from landmark to landmark just makes life so much easier. I completely agree. Susan?
I would
Please.
In terms of the counseling, I think the first bite is key. The option of observation, if you think it's benign, because most people have very little symptoms for most of these. They're not usually 7 centimeters with sleep apnea. And the third thing, the other symptom that they notice is numbness in their skin, sometimes their ear and their marge. Those are pre-op advice that's really worthwhile. And then I actually also tell them preoperatively that this is not big margin surgery. Our goal is to take it out. It could fracture. All those things that are easier to understand before they happen to you. Those are really the things that I slow down. I actually tell people they'll forget I told you about these things, especially the numb, because they'll walk in the morning after surgery and say, you know, I'm numb, and I'll say it's okay. That's normal. You'll get used to it. You can wear your earrings or phones or whatever. But those are the kind of things that make life interesting when you're receiving side of our treatments. So I've learned it. Thanks.
All right, it's 8 o'clock. Well, thank you so much for joining us. I think our next session is in a month from now. We didn't want to take too much time in the summer. But enjoy your fellowship. Join us for the next session. Usually we have 3 cases. It's a pretty rapid discussion, and these are all structured cases that we try to do the best we can for education. Please send us your feedback, your comments. Enjoy your fellowship. You know, if we get paid better, I would go back and become a fellow again. All right. Any last comments from Ara, Don? Susan, Jeff,
Yes, thanks everybody and welcome.
Thank you. Welcome to the year.
Okay, take care, guys.
Welcome, guys. Thank you.